Hello everyone. Today I will be presenting vitamin B9, commonly known as folic acid in its synthetic form and folate in its naturally occurring form. This is clinically important vitamin with broad relevance in biochemistry, hematology, OBGY, neurology and preventive medicine. As we go through this presentation, I will cover its chemistry, metabolic functions, clinical significance, deficiency states, diagnostic assessment, treatment and safety considerations. Let's begin. Vitamin B9 is a water-soluble vitamin scientifically referred to as folate when it occurs naturally in foods and folic acid when it is provided as synthetic compound. The chemical formula shown here is C19H19N7O6 with a molecular weight of 441 into 404 grams per mole. The term folate serves as an umbrella term for the many naturally occurring forms of this vitamin. Its name is derived from the Latin word folium meaning leaf, which is fitting because folate is abundant in dark green leafy vegetables. It is also important to understand that folate includes multiple related compounds, not just one molecule. These include tetrahydrofolic acid, which is the active form, methyl tetrahydrofolate, which is the main form found in blood, as well as methylene tetrahydrofolate, folinic acid, folacin, and tertiol glutamic acid. Historically, vitamin B9 has also been referred to by older names such as L-Kz factor, vitamin BC, and vitamin M. These remind us that the science of folate has evolved significantly over time as its physiological roles become better understood. On this slide, we introduce the chemical structure of folates. The key concept here is that folates consist of three distinct chemical moieties linked together. First, pterin means 2-amino-4-hydroxypteridine heterocyclic ring provides the chemical backbone. Second, p-amino-benzoyl group PABA connected via methylene bridge. Third, glutamic acid or polyglutamate residue attached through an amide linkage. One carbon units in various oxidation states may attach to the N5 nitrogen of the pteridine ring and or the N10 nitrogen of the p-amino-benzoyl group, enabling its role in single carbon transfer reactions. This structural organization is fundamental because it explains how folate derivatives participate in biochemical reactions, especially those involving one carbon transfer. Moving into the historical background, the discovery of folate begins with an extraordinary physician, Dr. Lucy Wills, working in Mumbai, India. Wills observed that pregnant textile workers suffered from a severe unusual macrocytic anemia that did not respond to the liver extract treatments that work for pernicious anemia. Crucially, she discovered in 1931 that marmite, a yeast extract, could completely reverse this condition. She named the mysterious active substance Wills factor. This was a landmark observation. It demonstrated for the first time that a specific nutritional factor was responsible for megaloblastic anemia of pregnancy and that it was distinct from the B12 related factor. Janet Watson and William B. Castle later formally named it Wills factor. Research in monkeys named it vitamin M and chick studies produce vitamin BC. All were unknowingly describing variants of the same molecule. In 1941, Herschel K. Mitchell and Esmond A. Snell and Roger J. Williams isolated the active factor from spinach leaves. They named it folic acid from the Latin folium, means leaf, recognizing that leafy greens were its richest natural source. That same year, it was demonstrated to be a growth factor for Streptococcus faecalis, forming the basis for the first serum assay. In 1943, Robert Stokestad at Lateral Laboratories in Pearl River, New York, achieved the first crystalline synthesis of folic acid, enabling large-scale production and rigorous scientific study. In 1945, Angier and colleagues published the full structural confirmation, proving the synthesized compound was chemically identical to naturally occurring L-Kz factor isolated from liver. Through the 1960s and 1970s, researchers elucidated how folate and vitamin B12 cooperate in synthesizing DNA nucleotides. Without folate, cells cannot properly divide, they enlarge and become megaloblastic rather than undergoing normal mitosis. The neural tube defect connection was first formally proposed by Smithels and colleagues in 1976, who found significantly lower folate levels in mothers of children with spina bifida. The landmark MRC vitamin study in 1991 and Kaziel's Hungarian randomized control trial in 1992 provided definitive proof. Periconceptional folic acid supplementation reduces neural tube defect risk by 50 to 72%. These findings trigger global action. The United States and Canada mandated folic acid fortification of all enriched grain products in 1996 and 1998, followed by over 80 nations implementing mandatory or voluntary fortification programs. NTD rates in the US fell by approximately 25 to 35% following mandatory fortification. Vitamin B9 has several essential biochemical and metabolic roles. Let's see key biochemical functions. First, it is critical for DNA synthesis. Specifically, 5,10-methylene tetrahydrofolate donates the methyl group to deoxyuridine monophosphate to form deoxythymidine monophosphate, which is essential for DNA replication. Second, folate is necessary for purine synthesis. Here, 10-formyl THF contributes carbon C2 and C8 of the purine ring during de novo purine biosynthesis. Without this, cells cannot adequately synthesize nucleic acids. Third, folate supports methionine synthesis. In this reaction, 5-methyl THF donates its methyl group to homocysteine, regenerating methionine through methionine synthase with vitamin B12 as a cofactor. Then this links directly to methylation reactions because methionine is converted to S-adenosyl methionine, the universal methyl donor used for methylation of DNA, RNA, proteins, lipids, and neurotransmitters. Folate is also involved in amino acid metabolism, including the interconversion of glycine and serine, histidine catabolism, and the conversion of homocysteine to methionine. Clinically, it is essential for red blood cell maturation, and it is also critically important for neural tube development during early embryogenesis. That is why folate has such major importance in both hematology and maternal fetal medicine. Folate occupies a central role in 1-carbon metabolism. It is a cornerstone of the interconnected pathways known as folate cycle and the methionine cycle. The main function of tetrahydrofolate is to transport single carbon units in different forms including methyl, methylene, methenyl, formyl, and formimimo groups. These 1-carbon units are indispensable for the biosynthesis and modification of numerous biological molecules. Several enzymes are especially important here. Dihydrofolate reductase reduces folic acid first to dihydrofolate and then to tetrahydrofolate. Methylene tetrahydrofolate reductase converts 5,10-methylene THF to 5-methyl THF. Methionine synthase, abbreviated MTR, transfers the methyl group from 5-methyl THF to homocysteine, and this reaction is vitamin B12 dependent. Thymidylate synthase catalyzes the conversion of DUMP to DTMP using 5,10-methylene THF, and serine hydroxymethyltransferase mediates the interconversion of serine and glycine. For doctors and medical students, this slide is especially important because it explains why folate deficiency can affect DNA synthesis, cell division, hematopoiesis, homocysteine metabolism, and fetal development all at once. The next area of focus is absorption, metabolism, distribution, and excretion of folate. Folate in food is roughly 1/3 in the form of monoglutamate and 2/3 polyglutamate. The latter is hydrolyzed to monoglutamate via reaction mediated by folate conjugate at the brush border of enterocytes in the proximal small intestine. Subsequently, intestinal absorption is primarily accomplished by the action of proton-coupled folate transporter, protein coded for by the SLC46A1 gene. This function based at pH 5.5, which is correspond to the acidic status of the proximal small intestine. PCFT binds to both reduced folates and folic acid. A secondary folate transporter is the reduced folate carrier RFC, coded for by the SLC19A1 gene. It operates optimally at pH 7.4 in the ileum portion of the small intestine. It has a low affinity for folic acid. Production of the receptor protein is increased in times of folate deficiency. In addition to role in intestinal absorption, RFC is expressed in virtually all tissues and is the major route of delivery of folate to cells within the systemic circulation under physiological conditions. When pharmacological amounts of folate are taken as dietary supplement, absorption also takes place by a passive diffusion-like process. In addition, bacteria in the distal portion of the small intestine and in the large intestine synthesize modest amounts of folate, and there are RFC receptors in the large intestine. So this in situ source may contribute toward the cellular nutrition and health of the local colonocytes. The biological activity of the folate in the body depends upon dihydrofolate reductase action in the liver, which converts folate into tetrahydrofolate. This action is rate limiting in humans, leading to elevated blood concentration of unmetabolized folic acid when consumption from dietary supplements and fortified foods near or exceeds tolerable upper intake level of 1000 microgram per day. The total human body content of folate is estimated to be approximately 15 to 30 milligrams, with approximately half in the liver. Excretion is via urine and feces. Under normal dietary intake, urine excretion is mainly as folate cleavage products, but if a dietary supplement is being consumed, then there will be intake folate in the urine. The liver produces folate containing bile, which, if not all absorbed in the small intestine, contributes to fecal folate intake and as cleavage products, which under normal dietary intake has been estimated to be similar in amount to urinary excretion. Fecal content includes what is synthesized by intestinal microflora. Here we review the recommended dietary allowances expressed as micrograms of dietary folate equivalents or DFE. For infants aged 0 to 6 months, the requirement is 65 micrograms DFE, and for 7 to 12 months, it is 80 micrograms DFE. For children aged 1 to 3 years, the recommendation is 150 micrograms DFE. For 4 to 8 years, it increases to 200 micrograms DFE. For 9 to 13 years, it is 300 micrograms DFE. For adolescents aged 14 to 18 years, the recommended intake is 400 micrograms DFE, which remains the same for adults aged 19 years and older. Requirement increase during physiological stress. In pregnancy, the recommendation rises to 600 micrograms DFE, and during lactation, it is 500 micrograms DFE. These values are especially important in public health, primary care, OBGYN, and nutrition counseling. Now let's talk about dietary sources of folate. Among the richest sources listed here is cooked beef liver with 215 micrograms in 3 ounces. Vegetable sources include boiled spinach providing 131 micrograms in half a cup, black eyed peas with 105 micrograms in half a cup, asparagus with 89 micrograms in 4 spears, and Brussels sprouts with 78 micrograms in half a cup. Other good sources include romaine lettuce, avocado, raw spinach, broccoli, mustard greens, green peas, kidney beans, and peanuts. It is also worth emphasizing the contribution of fortified breakfast cereals, which provide about 100 to 400 micrograms per serving, and enriched bread pasta or rice, which provide roughly 60 to 100 micrograms per serving. This is useful for counseling patients because it shows that both natural food folates and fortified foods can contribute meaningfully to daily intake. Now we turn to the clinical manifestations of folate deficiency, beginning with risk factors. The highest physiological demand occurs during pregnancy and lactation. Chronic alcoholism is a major cause because it impairs absorption, reduces hepatic storage, and disrupts metabolism. Malabsorption syndromes including celiac disease, inflammatory bowel disease, tropical sprue, and bariatric surgery can markedly reduce folate absorption. Hemodialysis can increase folate loss, and chronic hemolytic anemia raises folate demand because of increased red cell turnover. Several medications also predispose to deficiency, notably methotrexate, phenytoin, sulfasalazine, and trimethoprim. In addition, genetic polymorphisms, especially MTHFR C677T, may contribute. And finally, vitamin B12 deficiency is relevant because of the folate trap phenomenon, which functionally impairs folate utilization. So clinically, whenever we see one or more of these risk factors, folate deficiency should remain on our differential diagnosis. The classical hematological manifestation is megaloblastic anemia characterized by an MCV greater than 100 femtoliters and hypersegmented neutrophils. In more severe cases, patient may develop pancytopenia including leukopenia and thrombocytopenia. Some patients may show mild scleral icterus due to intramedullary hemolysis of fragile megaloblastic red blood cells. Mucocutaneous features include glossitis, described here as smooth, red, painful, beefy tongue, along with oral ulcers and angular stomatitis. There may also be patchy hyperpigmentation, especially over the dorsal surfaces of the fingers and toes and within the creases of the palms and soles. Gastrointestinal symptoms can include anorexia, nausea, vomiting, abdominal pain, diarrhea, and weight loss. Neuropsychiatric symptoms listed here include cognitive impairment, dementia, depression, irritability, forgetfulness, mood changes, and folate responsive neuropathy. This broad clinical picture showing that folate deficiency is not just a nutritional issue, it can be a multi-system clinical disorder. In a reproductive medicine and OBGYN, folate deficiency is especially significant because it is associated with serious pregnancy complications. Most notably, it increases the risk of neural tube defects including spina bifida, anencephaly, and encephalocele. It is also associated with a significantly increased risk of spontaneous abortion as well as placental abruption. The slide also lists preterm delivery with a risk of 16.94% and fetal growth restriction with a risk of 27.11%. Additionally, severe language delays in offspring are noted. For clinicians, this slide reinforces why preconception folate supplementation is one of the most important preventive intervention in maternal fetal care. Now let's begin the discussion of genetic disorders of folate metabolism, starting with MTHFR polymorphisms. The most common variant listed here is MTHFR C677T, also identified as RS1801133. This variant produces thermolabile enzymes with reduced activity. Individuals with the TT genotype have approximately 16% lower blood folate levels compared with those with CC genotype even with same folic acid intake. This variant is associated with elevated homocysteine and increased risk of cardiovascular disease, neural tube defects, and certain cancers. Another common variant is MTHFR A1298C, although its clinical significance is described here as less clear. Importantly, the treatment message is very practical. People with MTHFR variants can still process folic acid effectively. The CDC explicitly states that these variants are not a reason to avoid folic acid and 400 micrograms daily is still recommended. The content also notes that some patients may benefit from 5-methyl tetrahydrofolate or L-methylfolate supplementation. Next is hereditary folate malabsorption or HFM. This condition is caused by mutation in the SLC46A1, also known as the PCFT gene. It is characterized by both systematic and central nervous system folate deficiency. Clinical features include megaloblastic anemia in infancy, immune deficiency, seizures, and developmental delay. Diagnosis is suggested by low folate levels, elevated homocysteine, and confirmation of an SLC46A1 gene mutation. Also included here is DHFR deficiency, a rare autosomal recessive disorder that causes megaloblastic anemia and central nervous system folate deficiency. Treatment in that condition is folinic acid, which bypasses the need for DHFR. So in these inherited disorders, the pathophysiology is not simply poor intake, but a specific molecular defect affecting the folate handling. The next disorder here is cerebral folate deficiency, also called FOLR1-CFTD. It is caused by a mutation in the FOLR1 gene which encodes folate receptor alpha, and this impairs folate transport across the blood-brain barrier. As a result, patient may have normal serum folate but low CSF folate. Clinical manifestations include late infantile psychomotor regression, cerebellar ataxia, seizures, and dyskinesia. There is also MTHFR severe deficiency, distinct from common polymorphisms. In severe enzyme deficiency, patient can develop homocystinuria, developmental delay, and seizures. Treatment includes betaine, vitamin B12, vitamin B6, and 5-methyl THF. It is a very good reminder that normal serum folate does not always exclude clinically important folate-related pathology, especially in neurologic disease. Now we move to diagnostic assessment methods. The first category is direct folate measurement. Serum folate reflects current folate intake and balance and is described here as the preferred first-line test for nutritional deficiency. The slide gives a deficiency threshold of less than 2 nanograms per milliliter or 4.5 nanomoles per liter. A level of 2 to 4 nanograms per milliliter is borderline and greater than 4 nanograms per milliliter is normal. It is also notes that a cutoff of less than 7 nanomoles per liter indicates deficiency. Red blood cell folate reflects long-term folate status roughly over the 120-day lifespan of red blood cells and is a better marker for chronic deficiency. The reference value given is 366 nanograms per milliliter or higher, and the slide cites a sensitivity of 96% for folate deficiency. Among the functional biomarkers, plasma total homocysteine is elevated in folate deficiency, particularly above 15 micromoles per liter with a listed sensitivity of 94.7%. A level of 100 micromoles per liter indicates severe hyperhomocysteinemia. However, homocysteine is also elevated in vitamin B12 deficiency. That is why methylmalonic acid is so important. It remains normal in pure folate deficiency but becomes elevated in B12 deficiency, making it critical for distinguishing between two. Additional diagnostic tools include hematological assessment and genetic testing. On a complete blood count, folate deficiency may present with macrocytic anemia reflected by an MCV above 100 femtoliters along with decreased hemoglobin and hematocrit. In some patients, there may also be leukopenia and thrombocytopenia. The peripheral blood smear may show macrocytic oval red cells, also called macroovelocytes, as well as hypersegmented neutrophils with more than 5 lobes, and anisopoikilocytosis. A bone marrow biopsy is the rarely needed, but if performed, it may demonstrate hypercellular marrow and megaloblastic changes in erythroid precursors. For selected cases, genetic testing may be appropriate. These can include MTHFR genotyping for the C677T and A1298C variants, SLC46A1 sequencing for hereditary folate malabsorption, and FOLR1 sequencing plus CSF5 MTHF measurement for cerebral folate deficiency. So diagnosis should always integrate clinical context, laboratory data, and when needed, genetic confirmation. We now come to treatment. For standard adult therapy, the recommendation is oral folic acid at 1 to 5 milligrams per day for most adults. In severe cases, doses may be increased up to 15 milligrams per day. For patients with malabsorption and critical illness, parenteral therapy, whether intravenous, subcutaneous, or intramuscular, may be required. For pediatric patients, the dosing varies by age. From 1 to 11 months, the dose is 30 to 45 micrograms per day or 15 micrograms per kilogram per dose. From 1 to 10 years, the dose range is 0.1 to 4 milligrams per day with a maximum of 5 milligrams, and treatment may start at 1 milligram until correction. For hemodialysis patient, 1 to 5 milligrams per day is listed. A critical precaution is highlighted here. Vitamin B12 status must always be checked before or during folate replacement. Why is this so important? Because treating folate deficiency alone in a patient who is actually B12 deficient may correct the hematological findings but still allow progression of neurological damage, specifically subacute combined degeneration. This is one of the most important clinical safety message in the whole presentation. In the setting of pregnancy and reproductive health, dosing must be individualized according to risk. For women of reproductive age, the recommendation is 400 micrograms per day taken daily and ongoing. For routine preconception, the recommended dose is 400 to 800 micrograms per day, beginning at least 1 month before conception. During the first trimester of pregnancy, the recommended intake is 600 micrograms per day, and this continues throughout pregnancy. During lactation, the dose is 500 micrograms per day. For high-risk women, especially those with prior neural tube defect pregnancy, the recommended dose is much higher, 4 to 5 milligrams per day, starting at least 3 months before conception and continue through the first trimester. Women taking anti-epileptics are also listed as needing 4 to 5 milligrams per day throughout pregnancy. And in pregnancy with confirmed deficiency, the range given is 500 micrograms to 5 milligrams 3 times daily throughout pregnancy. This is clinically important because it stratifies dosing according to reproductive risk. An important therapeutic application involves methotrexate toxicity and leucovorin rescue. For patients with rheumatoid arthritis or psoriasis who are taking low-dose methotrexate, supplementation with folic acid 1 mg daily or 5 mg weekly can reduce side effects. For high-dose methotrexate rescue, the recommended agent is leucovorin, also known as folinic acid. The regimen listed is 15 mg, approximately 10 mg per square meter every 6 hours for 10 doses, beginning 24 hours after methotrexate. If methotrexate levels remain elevated, higher doses of 30 to 75 mg per square meter every 6 hours may be needed. Intravenous or intramuscular dosing is listed as 10 mg per square meter every 6 hours until the serum methotrexate is below 0.01 micromoles per liter. Treatment should continue until methotrexate levels are below 0.05 to 0.1 micromoles per liter. Additional therapeutic uses mentioned here include folic acid or folinic acid as an adjunct in methanol toxicity, leucovorin rescue in 5-fluorouracil toxicity, and leucovorin during pyrimethamine therapy to prevent bone marrow toxicity. For hereditary folate malabsorption, treatment begins with high-dose parenteral folinic acid. The slide notes that oral folinic acid, specifically 5-formyl THF, at very high doses may overcome the absorption defect. Treatment is lifelong and CSF folate monitoring is necessary to ensure adequate central nervous system levels. For cerebral folate deficiency, the recommended treatment is folinic acid or leucovorin, starting at 2.5 mg per kilogram per day and increasing up to 5 mg per kilogram per day. A very important distinction is made here. Use leucovorin, not folic acid, because folic acid cannot cross the blood-brain barrier. There is also mention of FDA-approved valcovorin for FOLR1 CFTD and notes that folinic acid should be avoided in MTHFS deficiency where it is contraindicated. This is an excellent example of why the exact folate formulation matters in clinical therapeutics. Let's talk about safety profile and drug interactions. Folic acid is generally described as well tolerated. There is no established toxicity at intakes below the upper limit of 1000 micrograms per day in adults. At higher doses, gastrointestinal upset may occur, but overall body storage is limited because folate is water soluble. However, there are several concerns at high doses. The first is the masking of vitamin B12 deficiency. High folate intake may correct the megaloblastic anemia while allowing neurological damage from B12 deficiency to continue. Second, high doses may lead to unmetabolized folic acid in circulation because DHFR becomes saturated. The long-term effects remain uncertain, but the possible concerns such as reduced natural killer cell cytotoxicity and possible cognitive effects in elderly patients with low B12. Third, there are cancer-related concerns with conflicting evidence suggesting that high folic acid intake may accelerate existing precancerous lesions while potentially preventing initial neoplasia. Finally, recent 2025 research is noted to suggest that excessive folate supplementation may have harmful effects in adults at high cardiovascular risk. So the key clinical message is that folate is essential and beneficial, but more is not always better. Drug interactions are highly relevant in everyday clinical practice. Methotrexate inhibits DHFR, the enzyme required to reduce folic acid into active tetrahydrofolate. Supplementation with 1 to 5 mg of folic acid per day can reduce methotrexate toxicity in conditions like rheumatoid arthritis and psoriasis without significantly reducing therapeutic benefit. Phenytoin, carbamazepine, and valproate are anticonvulsants that impair folate absorption and increase folate metabolism. Folate supplementation may reduce serum drug levels, which raises the risk of seizure breakthrough. Therefore, both blood folate and drug levels should be monitored. The interaction is described here as bidirectional. Folate deficiency can increase anticonvulsant toxicity, while folate supplementation can reduce drug efficacy. Sulfasalazine used in inflammatory bowel disease and rheumatoid arthritis inhibits intestinal folate absorption through competitive inhibition of PCFT and DHFR. Therefore, routine folate supplementation is recommended during long-term use. Trimethoprim and pyrimethamine also inhibit DHFR. With prolonged use, they can induce folate deficiency. In such cases, folinic acid rather than folic acid may be used to supplement without directly antagonizing the drug effect. Additionally, clinically relevant interactions are also important to recognize. Proton pump inhibitors and antacids reduce gastric acidity, which can impair the deconjugation of polyglutamate food folates. Long-term use has been associated with lower folate status, especially in elderly patients. Cholestyramine, a bile acid sequestrant, can bind folate in the gut and reduce absorption, so folate supplementation is recommended with long-term use. Alcohol or ethanol is described here as multi-mechanism folate antagonist. It impairs intestinal absorption, increases renal excretion, accelerates catabolism, and displaces folate from the liver binding sites. Heavy drinkers therefore have a very high risk of deficiency, and the slide recommends a minimum of 600 micrograms DFE per day. Oral contraceptives, particularly estrogen-containing formulations, may modestly reduce plasma folate levels. This becomes clinically relevant in women planning pregnancy soon after discontinuation, who should begin supplementation before stopping oral contraceptives. Finally, metformin is associated with reduced folate and vitamin B12 absorption during long-term use, so monitoring is advised in patients on prolonged therapy. To conclude, vitamin B9 is far more than a simple nutritional factor. Thank you very much for your attention, guys. Your feedback matters, and please like, share and subscribe to the Docsaab's Diary. Thank you.